Thank you. I would like to thank IWCLL Organizing Committee to ask me to talk about this. I will take a slightly different approach on this and try to give you an idea of where the MRD role stands at this moment in time and whether we can define duration of therapy. These are my disclosures. So I think aims of treatment in CLL is very important. I think that is the important question that we need to answer. The most important thing in my view is to improve the symptoms of the patient, quality of life, and that can be attained by disease control. And then you want the patient to have protracted treatment-free interval with prolonged survival. And essentially, if we can cure our patients, that would be the ultimate goal. And what influences that choice is important, really. We do look at patient's age and comorbidities. What is possible in that patient? Are all the patients, are we justified to have all the treatments that we've got at the moment? And then patient choice is very important as well. Not everybody would like to have very strong chemoimmunotherapy or very, very stringent visits to the hospital for venetoclax monitoring. And then the other important question to remember is what treatment options are available and appropriate. What is the previous therapy? What is the disease biology, which is very important to consider when we are using this in our treatment of our CLL patient. And then the treatment strategy, what are the future options, like looking at the biology of the disease, what are the targeted combinations? My colleagues have very eloquently talked about that in the previous talks. And eventually, what is possible to achieve in the treatment of CLL in individual patient? So I think that's the main question that is coming out of the theme that where we are going ahead with the treatment of CLL at the moment, really. And Professor Seymour has very nicely given his view about that essentially, are we going to use targeted therapy for a fixed duration of time for all patients? Or are we going to tailor the therapy depending on the needs of the patients? And I think that's the big question at the moment that we're trying to answer with all of these targeted molecules. We know that chemoimmunotherapy results in improved PFS and overall survival, and this is the data from the chemoimmunotherapy trials that we did in the UK, and clearly showing an improvement in those group of patients. Similar results have been shown in the CLL8 study, and clearly MRD negativity comes as a very important endpoint for achievement of long-term improvement in outcomes. And you can clearly see that high and undetectable MRD levels do matter. So little difference in MRD negativity between 2-year PFS is very kind of comparable if you have got MRD negative levels or intermediate levels, whereas very poor PFS for MRD high levels. But if you go to the 5-year data, it changes completely, and the patients who are really benefited from them are the patients who have achieved MRD negativity at the end of the therapy, whereas the intermediate and poor group are continuing to fall down. So MRD appears to be a very important prognostic marker in the chemoimmunotherapy era. And you can apply the mathematical model actually on the treatment of CLL, and essentially you have this curve here where essentially you've got patients who have got partial or no response, and you have got some patients who are destined to relapse, who are essentially in MRD positive remission, and there are some group of patients who might be cured, and you can apply that model based on this formula, which I don't know anything about really. But essentially, what you can do is that you have got a normal distribution of this MRD patients, but where you can see that 46% of these patients were MRD positive, and these are real Admire-Arctic patients. And you can see that the MRD negativity rates are going down to 0.001% and between 2.01%. And there are these 38% bone marrow MRD negative patients who are destined to relapse. But below that, you might have had some patients who've actually achieved cure, and that is the group of patients where we are seeing the long-term outcomes, which are exceptionally good in our FCR-treated trials. And every patient can have had this kind of curve where you can have log-resistant disease, which could be looked at the end of the treatment based on the MRD. And they can follow this curve right in the middle with this 2 standard deviation. So if you look at the progression-free survival, so for each log reduction in MRD level after chemoimmunotherapy, you can see that there is 33% risk reduction for disease progression per lot reduction in MRD level after chemoimmunotherapy. So clearly, in the chemoimmunotherapy era, there's no doubt that achieving MRD negativity at the end of treatment improves the progression-free survival. What's happening with the small molecules? So this is just taken one example of ibrutinib with the obinutuzumab trial, which was good combination and achieving MRD negative rates in the bone marrow of around 20% and peripheral blood of 30%. And then if you look at another trial that we did in ibrutinib and obinutuzumab trial, which is looking at two groups of patients. So there's a group of patients right on the left, which is just ibrutinib naive patients who essentially had 6 months of ibrutinib monotherapy. And on the right side is the patients who had the combination of ibrutinib with obinutuzumab. And what you can see here, that when we add obinutuzumab to the ibrutinib treated patients for 6 months, you can see that the CLL count drops down tremendously. And what it is telling us that the log reduction after addition of obinutuzumab later on is much higher as compared to the log reduction when you use ibrutinib and obinutuzumab together. And essentially, there were two factors which were telling us that. One was the disease bulk in the pre-obinutuzumab arm was lower in the ibrutinib exposed cohort as compared to the naive one. And the bone marrow CLL involvement was lower. And the CD20 expression actually reduced with ibrutinib monotherapy initially, and then it starts to rise again. So it becomes sensible to use this combination in the right way to achieve the right response. I presented some data on Galactic study. These were the patients who were treated with chemoimmunotherapy before, and then we added obinutuzumab as consolidation. And clearly, you can see that adding obinutuzumab later on does improve these patients' progression-free survival. So it is important to use the combinations, but in the right context, and I think that is an important way to take it forward. What about the long-term ibrutinib therapy? This is the Helios data, which is updated, and you can see that with continuous ibrutinib therapy, we are seeing more MRD negative rates. So you can see that the median follow-up rate at 34.8 months, you now see the MRD negative rates going up to 26.3%. Whether that translates into a PFS difference with continuous ibrutinib therapy is not clear. So every drug is different in terms of what we're doing in terms of MRD at the moment. And Professor Seymour obviously presented this early on, and this is the old ASH 2018 data where you can see that the patients who had undetectable MRD once they stop therapy at 2 years of fixed duration therapy, you can clearly see that 81 patients were still progression-free after a year. And now we know that from this meeting that number is only 72 after 22 months of therapy. So clearly fixed duration therapy gets patients into deep remissions, and the patients who achieve MRD negativity is an important thing to look at. The German CLL14 group data looks exceptionally good in the frontline setting, and you can see that the patients are achieving MRD negativity in 57% of the cases, which is an exceptional number really in the frontline setting. But that was the examples of the fixed duration, but what's happening with continuous therapy, and this is data from Nitin Jain, and essentially previously untreated CLL with continuous ibrutinib and venetoclax, you can see that the MRD negative rates are going higher as with the continuous therapy as well. So there is an argument about individualizing therapy, and at the moment, what we don't know is whether one approach is better than the other. And this trial might help us to identify this. This is a Captivate study, which is looking at ibrutinib in combination with venetoclax. So patients are going to get ibrutinib for 3 cycles, and that would be followed up with venetoclax 400 milligrams for 12 cycles. And then the patients would be randomized based on their MRD results at that point. So patients who have undetectable MRD will get 1-to-1 randomization to get placebo or ibrutinib, or undetectable MRD is not confirmed. Those patients will be randomized to ibrutinib or I+V. So the initial data on this trial looks extremely good, and you can see that after cycle 15, 86% of the patients are achieving MRD negative rates at that point. So in Clarity study, what we've done as well is use the same, is using the concept of MRD negativity again. So patients get ibrutinib for 2 months, followed by 12 months of venetoclax, where we do the primary endpoint analysis. So the MRD negative rules are that if the patients become MRD negative at month 8, they will stop I+V at month 14. If they are MRD negative at month 14 or month 26, they will stop I+V at month 26. And if they stayed MRD positive at month 26, they will continue ibrutinib monotherapy from there on. Now we have got an expanded cohort, which is essentially after month 26, we will be using patients to go into venetoclax for another 12 months. And we'll see whether continuous therapy with venetoclax in combination with ibrutinib for another year will make any difference at all in that group of patients. So the other question is really when to stop targeted therapy in CLL. So if you consider that this is the CLL burden in your CLL patient, when you see that they achieve a IWS-CLL CR, still there are millions of CLL cells at that point hanging on. When we go to the MRD negative CR, there are nearly about 10 million cells still there, which essentially patient might be harboring. So our ability to detect the pure negative MRD negativity we have still not got the techniques to reach there, but we're trying hard. So at the moment, what we're doing in the FLAIR study, which is using ibrutinib with venetoclax in frontline setting, and that's been compared to ibrutinib versus FCR, is the patients who achieve MRD negativity at 1 year of therapy. Initially, we were stopping their treatment 6 months down the line. And if they were doing it at 2 years, they get another 6 months of therapy, and then they stop. And if they do it at 3 years, then another 6 months of therapy. So we've changed the rules now slightly, and what we've done now is essentially giving them a year more of treatment if they get MRD negativity at 1 year, and if they get MRD negativity at 2 years, they get 2 more years of therapy. And the third year, they will go down and have 3 more years of therapy. And the concept really is to bring the red bars down as much as possible so that we can get down to that area where essentially we would be able to say that these patients, some of these patients might be able to get an effective cure. Slides always stop when I'm...
Can someone from the technique help?
I think they're looking at that, yeah.
Thank you. So as a result of that, the IWCLL guidelines now do say that we need to check MRD in clinical trials. So that is a desirable goal in our patient. But what about general practice? Can we apply MRD now at this moment in time to treat all our patients? And the answer to that question is really it's not generally indicated at this moment. And I would agree with that at the moment, if we are going to give somebody some therapy, if it's a fixed duration therapy, then doing an MRD at that point at the end of the treatment will help us to prognosticate that patient and tell them how they're going to do in future. But essentially, it's not going to change the therapeutic options for that patient. Whereas if we have got a targeted therapy combination where we are going to make an intervention at that point, in that setting, yes, MRD would be very useful for us, and that's where we are heading towards, and it might become a normal tool for all our patients to be treated in this setting. So the other problem really is, which people have touched on, is development of resistance, and it was an exquisite talk from Dr. Lando yesterday about resistance. And the other problems that we're seeing is the high cost of continuous treatment, which is an issue as well. And there are biological rationales for treatment windows to avoid resistance. That's what we are looking for, and combination actually would help us to do that. Another approach that we are taking here at the moment is using this concept which actually comes from prostate cancer, is stopping therapy to avoid treatment resistance. And this is a trial that is in conception at the moment. Really, it's looking at 800 patients who have been treated with ibrutinib monotherapy, and some of the flare patients might be going into this trial. And these patients will be divided into two groups. One will get continuous treatment until disease progression, and the other group will go into this intermittent treatment strategy until strategy failure. And primarily, these are the patients who've been on ibrutinib for more than 2 years, and they are in complete remission. The lymph nodes would be less than 2 centimeters in size, and the CLL count would be less than 5. And in those patients, we're going to stop therapy and then closely monitor them and see what happens to them once you stop therapy in patients who achieve good deep remission with ibrutinib. And if those patients start to relapse at some point, they will be going into the restart treatment strategy, and hopefully they will achieve remission again. And they might be able to stop treatment again after 12 months of therapy. So this stop and start strategy might be able to tell us if we are able to stop therapy in some group of patients on ibrutinib, and whether restarting the therapy would be able to get them into remission again. So I think what I would like to say at the end is, can MRD be used to determine subsequent treatment strategy? I think, yes, we have seen that it is required to optimize combinations, BCL2 inhibitors, BCRI inhibitors, antibodies, and chemotherapy. We've heard in a lot of detail in this meeting, and in the combinations, MRD is a very, very useful tool to actually get us there. It will help us to optimize duration of component therapy. There are unanswered questions. Do we really need BCL2 antagonist only for 12 months? BCRI inhibitors for ongoing therapy. Antibodies like CD20, whether we need to use them when the disease bulk is low. And all of those questions are up in the air at the moment. So I think I will conclude that MRD level is relevant for most, if not all, clinical trials, and can be used to identify optimal combinations and duration of treatment components. It is a better predictor of PFS and overall survival than response rate for most regulatory consideration now. PFS is the key endpoint for acquiring license. MRD may be an intermediate or accelerated endpoint as long as PFS benefit is confirmed. But there are funding and logistical challenges. MRD is not available to everybody, and essentially we'll have to look at how relevant it will become in our general practice. And then there are obviously technical issues which are related to MRD as well. I would like to acknowledge my mentors, Professor Hillman, Professor Andy Rostron, Dr. Gina Doody, and all of my other colleagues who have helped me. Thank you.
Thank you very much, Dr. Munir, for an excellent overview. We have time for one question. Please come to the microphone and identify yourself. Munir, I would have a question to your very interesting static trial. Since you plan restarting of the patient, is it necessarily only ibrutinib, or would you allow any BTK inhibitor, since we don't know how long the treatment interval is, and we know from our own experience it's very hard to establish already the retreatment of patients in a study protocol due to the changes in development of novel drugs?
So yeah, any BTK inhibitor would be allowed to go into the study. So it's not only ibrutinib, but this is looking at both relapsed refractory patients as well as frontline patients as well. But any BTK inhibitor would be allowed.
Okay, Dr. Rai.
Very interesting discussion, but I wanted to get your opinion about patients who are not on clinical trials. And you had some opinion, but it did not answer my question. What do we do in clinical practice?
I think in clinical practice, Dr. Rai, I think my answer is pretty straightforward. If it is not going to change the therapeutic option for our patients, I don't think that MRD would would be changing anything for that patient. So, but it will help me to inform the patient how well you're going to do in future, and if there are other clinical trial options for those patients. So MRD is very, very useful in our clinical trial settings at the moment. It might become the routine that we do to change the therapeutic options for our patients. But where we stand at this moment in time, I think for general practice, not everybody would benefit from that because it doesn't change the options for our patient at this moment in time.
Thank you very much.
Thank you.